Okay. Hi, everyone. We'll allow everyone else another couple of moments to trickle in, but we'll get started by introducing the program and introducing the speakers. So tonight we're excited to have all of you join us for Smilow Shares. This is, I believe, the fourth of four from the Yale New Haven group, kind of across our health system. And today we're highlighting many of our amazing physicians here based at Smilow Waterford, as well as our partners from the New Haven campus. And so I'll ask everyone to introduce themselves, starting with Dr. Bulgaru.
Hi, good evening, everyone, and welcome to Smilow Shares. I'm Anca Bulgaru, medical oncologist at Smilow Waterford, and I'll be talking tonight about individualizing treatment options for um, hormone receptor positive, HER2 negative breast cancer.
Hi everyone, my name is Siba Haykal. I'm a plastic surgeon and I'm the section chief of Reconstructive Oncology, and I'll be talking about the different options for breast reconstruction.
Hi everyone, I'm Meena Moran. I'm a radiation oncologist and I'm the section chief of breast radiation oncology across the Yale sites. And I'm going to be just going over an overview of breast cancer and some of the recent updates in terms of de-escalation.
Great. And I'm Dr. Ellie Proussaloglou. I'm a breast surgical oncologist. I help take care of patients both at our New Haven site as well as our Waterford site. And I'm the Yale lead for high-risk breast care across the system. So we're so excited to have you. Bear with me for just one moment while I share my screen, and then we will get started. Okay. So to get started today, I'm going to give a brief overview of some of the surgical care of breast cancer with a focus on some of the ways that we have started to de-escalate care for surgery of the axilla. Or the underarm. And before I get started, I forgot to mention throughout the presentation, either mine or my colleagues, if you have any questions, we encourage you to put them in the Q&A section of Zoom. We'll try our best to get to them after our respective talks, and we'll certainly have some time at the end. So, as probably everyone on this call knows, especially now at the end of Breast Cancer Awareness Month, breast cancer is the most commonly diagnosed cancer in women and the #2 cause of death in women in the United States. And it's extremely common. 1 in 8 women in the United States is diagnosed with breast cancer in their lifetime, and the age of diagnosis is getting younger and younger each year. The good news, however, when you hear all of this, it can be really easy to feel overwhelmed by the possibility that breast cancer may happen to you. But one of the first things I tell many women when I meet them in my surgical oncology clinic is that most breast cancers are caught early and in treatable stages. And I should note that breast cancer can also happen to men. It's much less common. About 1% of new breast cancer diagnoses happen in men compared to 95+% in people assigned female at birth. But we certainly encourage people, regardless of their sex and gender, to know their breasts, know their bodies, and get appropriate screening. I think it's really important to remember that breast cancer treatment is multidisciplinary. So here on the slide, I have a photo of our Smilow Cancer Hospital at Waterford. We feel privileged to practice here and take care of you all in such a great site. And at this site, we now have specialists from all of the fields that we use to help treat breast cancer. My focus, as I mentioned previously, is surgery. So along with Dr. Haykal, I help take care of the surgical management of breast cancer. I help take the cancer out, and Dr. Haykal helps with complex reconstruction, as she'll talk to you about. Breast cancer surgery involves cancer on the breast, and it also involves cancer under the arm in the lymph nodes of the axilla. Additionally, radiation therapy is a very important part of comprehensive breast cancer treatment. We like to say, and Dr. Moran may talk about this a little bit more in her talk, that we have 20 to 30 years of data that tell us that big breast cancer surgery or mastectomies are equally as effective as smaller breast cancer surgeries or lumpectomies, also called partial mastectomies, at treating most breast cancer that we diagnose, assuming it's small enough compared to the area of surgery. But I tell people all the time, my lumpectomy is not going to be as good if we don't partner with people like Dr. Moran to give you local treatment with radiation therapy to the breast. It's really effective at helping decrease the chance that cancer comes back. I then get to partner with smart people like Dr. Bulgaru to help take care of patients for the whole body. And so surgical management of breast cancer is an important part of early stage breast cancer. But even more important at times is thinking about treatment to protect the entire body and decrease the chance that breast cancer goes elsewhere in the body or comes back over time. This can be part of targeted treatment, such as pills, anti-estrogen therapy, or other targeted medicines in breast cancer treatment, along with IV chemotherapy. Not all breast cancer needs chemotherapy, but we're certainly fortunate to provide care at this site where we're able to really thoughtfully think through how do we best take care of you and your disease as opposed to using a one-size-fits-all approach. A lot of times people come to my office really scared because they've seen images like what's up here in the far left of what's called a radical mastectomy, which is the kind of treatment women were getting in the 1800s and 1900s, honestly, even through probably the mid 1900s, 1950s and 60s in some parts of the world and country, because we thought that the best thing to do was to remove everything surgically. What we've learned over time, as I indicated on the slide before, is that we have to be thoughtful about what surgery and what additional treatment in combination is best to treat our patients. Nowadays, in 2024, we're so fortunate to do smaller and smaller surgeries and to be really thoughtful about the kind of care that we can provide. When we think about surgery for the breast, as I alluded to before, many cancers are now amenable to smaller breast surgeries called breast conservation, also called lumpectomy or partial mastectomy, where we use specialized guides such as wires or tagless localization to find the area of abnormality, seek it out, and remove those cancer cells while leaving most of the breast behind. We often have really excellent cosmesis in this setting. And one of the sort of new frontiers of reconstructive surgery for breast cancer includes doing a lumpectomy, a smaller cancer surgery, and partnering with a plastic surgeon to actually do a reduction and lift at the time of your surgery, if that's best for you. From a mastectomy perspective, we now know that we don't have to take all the tissue off the chest wall, like in that photo I showed you before. We can do mastectomies in a variety of approaches, so I encourage you to talk to your provider about best option based on your breast shape and size. And it can include removing all of the breast tissue and closing you flat, removing the nipple areolar complex and all the tissue underneath and doing some sort of reconstruction, or doing what's called a nipple-sparing mastectomy, which is safe even in our highest risk patients, where we make an incision, take off all the breast tissue, leaving the nipple and the skin behind. When we do surgery for breast cancer, there are some nuances, but we usually recommend looking at the lymph nodes under the arm in a procedure that's called a sentinel lymph node biopsy, which is a fancy way of saying that we look for the first lymph nodes that help drain the breast of fluid. All of us have lymph nodes throughout our body, including under our arm, and fluid flows from the breast to those lymph nodes and then to the rest of our body. And so there have been many big studies that have shown that by checking those first lymph nodes under the arm, we have a pretty good assessment of whether or not there is cancer in the lymph nodes, which helps us sort of identify how concerned or not concerned we should be about the rest of the body and possible metastatic disease or disease elsewhere. We inject the nipple usually, or the tumor itself, with some specialized dye, either dye that emits a signal or dye that's blue, and then make a little incision under the arm and find lymph nodes just like this one that we remove and send to pathology. In the past, when we took those lymph nodes out and sent them to pathology, any patient that had any cancer in their lymph node was recommended to have a bigger lymph node surgery, something called an axillary lymph node dissection. Here on the left is a pathology slide of a lymph node showing an area here in the center that's a little bit darker purple, more cellular. It just looks abnormal compared to the nice fluffy pink and light purple here on the edges. This is a lymph node that has cancer in it. And again, in the not too distant past, we said, well, if there's cancer in the lymph nodes, there may be more cancer in more of the lymph nodes than we checked. And so the safest thing to do is probably to take out all of the lymph nodes. Axillary lymph node dissections typically remove level 1 and level 2 lymph nodes under the arm. These are the lymph nodes just lateral or to the side of the pectoralis muscle and the lymph nodes underneath the pectoralis muscle. The level 3 lymph nodes that are all the way in the center of the chest, closer to the sternum, are usually left as is. However, you can imagine taking more lymph nodes, bigger surgery, and bigger risk of complications. And we've learned pretty quickly that axillary surgery has significant side effects. This is much more pronounced when we do bigger surgery, like axillary lymph node dissection, but we can also see it sometimes when we do a sentinel lymph node biopsy alone. The most common side effect is lymphedema. You can see here in the drawing the affected arm compared to the unaffected arm. Women will sometimes complain of sort of mild symptoms like swelling of their fingers, difficulty getting their rings off and on, or sometimes much more severe instances where their whole arm is full, swollen, and perhaps limits their ability to do their functional activity. We also know even after small lymph node surgery, sometimes there's some pain and stiffness in the arm. There's often numbness, especially on the inside aspect of the arm right here because of little nerves that we cut to take the lymph nodes out. And rarely, but importantly, sometimes there's actually functional changes of the arm, especially if we do that really big surgery and have to take lymph nodes out that are close to the important nerves that allow us to have normal range of motion. Now, this is a really busy slide, and we're going to skip to a simple summary, but smart colleagues, surgical colleagues, designed a trial to ask, do we have to take out all of the lymph nodes to be equally as safe when 1 or 2 is positive? And specifically, they said, how about in people that have small tumors with no lymph node disease from imaging or exam before surgery, and their cancers are driven by hormones, estrogen and or progesterone? We know these tumors tend to be a little bit less aggressive. And in people planning lumpectomy, as I mentioned before, we recommended that all of these patients have radiation therapy by Dr. Moran and her colleagues to decrease the chance of cancer coming back. So we really asked the question, is more surgery better? Or is the impact of removing more lymph nodes or more axillary surgery equivalent to using radiation to the breast and the underarm when we find 1 or 2 lymph nodes that are positive? So what we found in this study is that outcomes are the same. Again, this is for small, early stage hormone positive cancers. We often in the breast cancer literature look to see what's the impact on survival or the chance that cancer gets serious enough to make the patient pass away, as well as how long do people live without cancer coming back or disease-free survival. And the outcomes were the same. The blue line is with sentinel lymph node biopsy alone, not doing big surgery. The orange line is with the big underarm surgery or the axillary lymph node dissection. We then asked, well, what about, these are all patients that are planning for radiation because they had a lumpectomy. Can we think the same way about people that have a mastectomy or have their entire breast removed? Does radiation work in those instances if we find 1 or 2 lymph nodes that are positive? So this other trial, the AMROS trial, answered that question, and same, showed us that axillary radiation, the dotted blue line, and axillary lymph node dissection, or the bright red line, had equivalent outcomes for both that disease-free survival, cancer coming back, and overall survival from breast cancer. And so, through this, we've learned that when we take people with early stage cancers to surgery, we can safely do a sentinel lymph node biopsy and often spare additional lymph node surgery. We've also recently found that if imaging and an ultrasound before your surgery finds 1 lymph node that is abnormal, and you have only one or two lymph nodes total that are abnormal, we can apply these same principles. So again, low volume disease in the lymph nodes means we can often spare or avoid axillary lymph node dissection, which makes quality of life and patient complications, quality of life better, patient complications lower. Now, one of the things I like to sort of think about is what is coming next. So a big trial was published just, I believe, late last year in 2023 called the SOUND trial. This is one of the things that we are thinking about in patients that we see throughout the Yale system. And it said, okay, well, we know that we should be avoiding big axillary surgery if one or two lymph nodes are positive. Do we have to check lymph nodes at all? This study looked at at patients with small breast cancers, smaller than 2 centimeters, who had normal preoperative ultrasound, so their underarm, the lymph nodes looked normal. It had a variety of tumor types, but most patients were after menopause, 50s, 60s, and 70s. And most patients had that same hormone-positive cancer that I mentioned before, slow growing, less likely to spread. They looked to see if sentinel lymph node biopsy and the information we gain from that leads to better outcomes versus treatment instead as we planned, whether it's radiation, if patients are getting lumpectomy, or whether it's radiation, people are getting lumpectomy, or whatever sort of chemotherapy or pills are recommended by their team. And interestingly, we found that outcomes were the same. Now, this is an early publication of the data, but we found the chance that cancer comes back in the lymph nodes is very, very low in both groups with no major change. And it's encouraging for us because all of us surgeons have seen that even though the risk of lymphedema is low in people that get sentinel lymph node biopsies, typically 5% or less, it's not zero. And so we want to do everything we can to help minimize unnecessary surgery while making sure that the surgery we're performing for you is the surgery you need for your cancer and is going to give you the best outcomes. So we'll stop there. I don't know if there's any questions in the Q&A. Let me take a look, stop sharing. Otherwise, I don't see anything right now. I think we can transition to our next speaker, Dr. Haykal.
Thank you so much. Okay, great. Let me share my screen. All right. Can you all see my screen? Wonderful.
Yes.
Thank you so much. Okay, great. So we're going to follow with reconstruction after breast cancer. So what are the options? So breast reconstruction can be divided into immediate breast reconstruction, which means at the same time as mastectomy, or delayed breast reconstruction, which is any day after the mastectomy. So the types of breast reconstruction are typically divided into two, either using tissue expanders and implant-based reconstruction or using your own tissue. And how do we determine the best decision? It really depends on patient preference, the need for postoperative treatments such as chemotherapy and radiation, available donor sites, other medical issues, and recovery time. So I'll talk about different types of breast reconstruction, the first one being aesthetic flat closure. So what does aesthetic flat closure mean? That means that when we're operating with our breast surgeons, we take away any redundant skin that is left behind to make sure that we have a nice scar with no skin redundancy, so no excess skin. And the pattern of the scar can look either U-shaped or joint, and we can have different shapes. Another type of breast reconstruction is oncoplastic reconstruction. So this is when a plastic surgeon helps the breast surgeon when a lumpectomy is being done. So we're rearranging the breast tissue after a lumpectomy for breast cancer to achieve the best aesthetic result possible. So when a portion of the breast is removed, it can cause some dimples, some divots in the breast, and some asymmetry between the two breasts. So this is a very good option for patients who are undergoing a lumpectomy, but also have very large or very ptotic, or that means saggy breasts. So we therefore do a breast reduction on the other side or a breast lift at the same time as the cancer is removed. Let's talk about implant-based reconstruction. A one-stage direct-to-implant is when we put an implant at the same time as a mastectomy. It eliminates the need for tissue expansion. The breast reconstruction can be done in one stage. Usually the candidates are patients who have small breast size, small tumor size, and depends on the type of mastectomy. However, it can lead to high revision rates. The gold standard is a two-stage procedure where we put a tissue expander first, either underneath or above the muscle, most commonly now above the muscle, and we go back to the operating room at a later time after we filled this tissue expander with fluid, and we go back to the operating room to exchange for a permanent implant. This is an example of where the tissue expander would be placed. So typically now we put them all above the muscle. And sometimes we use what we call an acellular dermal matrix, which is cadaveric skin that we use to try to resuspend some of the tissue. This is what tissue expanders look like. So they are filled with saline. They tend to sit higher. They look a little bit more fake. And this is after an exchange for a silicone implant. A silicone implant tends to be a lot more soft. It feels more natural. What are the possible complications with implant-based reconstruction? So typically there are no complications. However, they tell us the shelf life of an implant is about 10 to 15 years. There is a chance that the implant can rupture. The body sees an implant as a foreign body and automatically forms what we call a capsule around it. So that's the body's natural reaction to an implant. However, sometimes that capsule can get hard, can get tight, can distort the implant, can cause a lot of pain. That's called capsular contracture. Other things are infections or a fluid collection or a blood collection. This is an example of a tissue expander before and after mastectomy. This is an example of a direct-to-implant reconstruction where the nipple and the areola was spared, and you can see the scar is below the fold. And typically, with a direct-to-implant, we can go about the same size, maybe slightly bigger, but ideally this is reserved for where the nipple and the areola are in a nice location. This is an example of the effects of radiation on an implant. It can cause some redness. The advantages of an implant-based reconstruction is that it's a quicker procedure. It's a shorter recovery time. You get to choose the size of your reconstruction. We're only operating on one area. The disadvantages is that it requires more than one surgery. You can sometimes see and palpate the implant. You can have chest wall animation depending on if it's placed above or below the muscle. There's a risk of infection. There's a risk of capsular contracture, a risk of rupture. The use of radiation can lead to a higher failure rate. There's also some types of implants and expanders can cause a fluid collection, where if we sample the fluid collection, it comes back as something called anaplastic large cell lymphoma. That typically happens with textured implants, and most commonly, and I don't use any textured devices in my practice, so these most commonly happens with textured devices. And then there's also something called breast implant illness, where we know that some women, whether or not they have implants for either augmentation or reconstruction purposes, they just don't do well with implants. The other type of reconstruction is using your own tissue. That's called autologous reconstruction. The most common place that we can take it from is from the belly or the abdomen, but there are other locations that we can take it from as well. So these are the different areas. We can take it from the belly, we can take it from the thigh, either from the front, the top, or the back. And we can also take different areas in the back. So I'll explain some of them. So this is using your own tissues to create a breast. It avoids all the complications of implants, and it's a pretty nice donor site. So back in the day, we used to take the whole muscle from the belly along with skin and fat. And we used to flip that into the breast. Now we have something a bit more sophisticated, which is called the DIEP flap, the DIEP flap. So what does this mean? So this is a cross-section of your belly and the muscles in your belly. These little vessels are about less than 1 millimeter in size. So we usually do a CT scan of the belly to make sure they're there. And during the surgery, we follow them all the way down to the groin, where they become about 1 to 2 millimeters in size. We disconnect them from the groin, and we reconnect them in vessels that are located underneath a small piece of cartilage in the rib. So this involves using loops and a microscope to do that, and it's a very intricate, delicate procedure. You end up with a scar from hip to hip and a scar around the belly button. It's like a tummy tuck. And we reposition the tissue in the belly, in the breast. We also sometimes use a small nerve to try to bring back sensation into that flap. One side takes about 6 hours, 2 sides takes about 10 hours. You're in the hospital for about 2 to 3 days. The first 24 hours are the most important because that's when we watch to make sure there's good blood flow, that we've connected between those vessels. And then there's a bunch of devices that we use to make sure we're doing proper monitoring. This includes a Doppler, and this is what we call a Vioptics, which allows us to tell us how the blood flow is working in this flap. The complications are, most of the time there are no complications. However, we're operating within the muscle in the belly. So although we try not to take any muscle, there's always a small risk of hernia or a bulge. There's always a small risk of losing a bit of the blood flow. There's a risk of delayed wound healing or infections, a blood collection or a fluid collection. And the chance of not being able to make that connection work happens in about 1% of cases. This is an example of someone before their mastectomy, and this is an example after their mastectomy. So all of the tissue that is inside comes from the belly, and this is what the scar would look like. And we can use it in patients, in people of different sizes, and we can make breasts of different shapes, along with doing a lift at the same time of the breasts. That would an example of an immediate reconstruction using the own tissue. However, if you haven't had reconstruction and now you have a scar, we can also still use the belly. This is someone who came in having had radiation and a previous bilateral mastectomy, and we use the skin from the belly to reconstruct. So now what you notice is the scars are a little bit different. The shape is a little bit more elliptical because we have to use more skin from the belly. And there's something called the delayed to immediate reconstruction, where we put a tissue expander initially at the time of the mastectomy, and we remove the expander later in order to put your own tissue at a later date. What are the advantages? Most of the reconstruction is done at that surgery. We're using the own tissues. It's lifelong. It's the best substitute for natural looking breasts. The benefits are a tummy tuck. The disadvantages is a longer procedure. It's a longer recovery time, about 6 to 8 weeks of no heavy lifting, pushing, or pulling. It's a separate donor site. It may require revision surgeries. There's a small risk of losing the flap. We can only use the belly once, and there's more scars. Implant and using your own tissue. This is when we use a latissimus dorsi muscle along with implants. And this is typically used after, for example, a lumpectomy defect. This is an example of skin and fat that was taken from the back to reconstruct and shape that portion of the breast. And this is someone who had previously had a mastectomy, and we used a flap from the back as well as implants at the same time. The advantages of this, that we can use this in someone who has been previously radiated. It can be used in patients who are too thin, who have previously had a tummy tuck. The disadvantages that comes with it, disadvantages of all the risks of implants and all the risk of using other tissue from your other parts of the body. The last thing that we do if we remove the nipple and the areola is we reconstruct it. And this is completely elective. It can be done under local anesthetic. And we also do some tattooing. We basically use origami to shape some tissue to make a nipple. This nipple is not like a normal nipple. It does not have sensation. It looks something like this. And then we have our APP tattoo the area depending on the color. We can do different colors. And this is an example of a 3D tattoo where we don't bunch up any tissue, but we reconstruct and we basically use tattooing to create a 3D nipple. Thank you so much, and I welcome any questions you might have. I don't see any questions, so I'll leave it to our next speaker. You're on mute.
Can you help me? I'm not really sure.
We can hear you now.
Yes, but okay. So I was saying thank you very much for your talk and for the important work that you're doing for all our patients. So after patients have surgeries, they come to meet with a medical oncologist. Many times we meet actually with our patients even before the surgery to ensure there is no need for any kind of treatment before the surgery is carried out. So I have no conflict of interest, and I'm going to talk first about the different types of breast cancer subtypes. This is statistics from the National Cancer Institute through their SEER program. And one can see in this diagram that 70% of the breast cancers are hormone receptor positive, HER2 negative. And other subtypes would be the HER2 positive, hormone receptor positive, HER2 positive, hormone receptor negative, HER2 positive, and triple negative. So my talk is going to focus on the most common subtype, the hormone receptor positive.
Dr. Bulgaru, I think we may have just lost your connection. Can you still hear us?
Also, are you guys seeing her slides? Yes.
The relative survival for the breast cancer is estimated to be 91.2%. And as you can see here, over the last few decades, actually the overall survival has gradually improved. And for all cases of breast cancer together, we estimate that 91.2% of the patients would be alive and at 5 years. And with the highest survival rate for our subgroup of patients that I'm going to focus on, the hormone receptor positive, HER2 negative disease. So during our meeting after the surgery is done, the question is, how do we address the risk of recurrence in case there is any micrometastatic disease that is left behind, in case there were any cells that were not removed at the time of the surgery, and how do we increase the chance for cure? And I'd like to make this a very important point that the indication for adjuvant treatment is not influenced by the extent of the surgery, I meant to say here. So if someone has a lumpectomy or a mastectomy, there could be a different risk for recurrence that depends on the tumor characteristics such as stage, grade, the receptor status, if there is any lymphovascular invasion. But we also, when deciding about what type of treatment we would offer, we take into account other characteristics of the tumors based on the genomic analysis, the health conditions that the patient is in, the age and menopausal status, and ultimately the patient's preference. We do know that the for treatment of breast cancers that are driven by the hormonal receptors, the mainstay of systemic treatment is represented by the endocrine therapy. That could be with different medications, tamoxifen, aromatase inhibitors such as anastrozole or letrozole, suppressing the ovarian function in some high-risk premenopausal women, and applying this type of therapy for at least 5 years, but sometimes extending it to 10 years. Because as is shown in this graph, although we do have a very high chance for cure for this type of cancer, some of the patients are at risk for late recurrence after year 5 to year 10. So sometimes we use chemotherapy, and the benefit of the chemotherapy depends on the risk of recurrence and on the biology of the disease. So we look, as I said, at the pathology characteristics, at the pathology report, but we also have nowadays important genomic tests available. And there are several of them: Oncotype DX, MammaPrint, EndoPredict, just to name the few. What do we do with such testing? So we do know that in the past, we used to recommend chemotherapy to any cancer that was above a certain size, let's say 1 centimeter, with a higher grade, or even a lower grade, a larger tumor, especially if the lymph nodes were involved. But then the same way our surgical colleagues showed us that it's worth taking a step back and looking to see if the treatment is absolutely necessary. We do that as well when we recommend systemic chemotherapy. So we have this genomic analysis that basically looks at the true aggressiveness of the cancer as represented by certain genes that are turned on inside the cancer cells. And one of the most commonly used testing is with Oncotype DX that looks at 21 genes inside the cancer cells, and also provides a quantitative estrogen receptor score, progesterone receptor, and HER2. So this test is strongly associated with a rate of distant recurrence, and a low recurrence score indicates a significantly lower rate of distant recurrence and lower likelihood of chemotherapy benefit, whereas a higher score would indicate a higher risk, and therefore the benefit of chemotherapy may be justified. So when we submit the request for the testing, actually our colleagues from the pathology department will send a part of the tumor that was resected at the time of the surgery to a special laboratory. And 2 or 3 weeks later, we get the report in this form that gives us a recurrence score that could be anywhere from 0 to 100. We consider a low risk score if the recurrence score is less than 25. And in the second column, we have an estimation of what would be the risk of distant recurrence at 9 years, provided that that patient undergoes adjuvant hormonal therapy. That means takes anti-hormonal treatment to block any residual cells from growing. And then it also estimates, the test also estimates what's the benefit of chemotherapy. These risk estimates could be different. Someone who has here a recurrence score of 35 could have a significant risk of recurrence and, let's say, more than 10 to 15% benefit from chemotherapy. So we find this test extremely useful to tailor the need for chemotherapy and avoid exposure to significant toxicities for patients who do not need such treatment. But on the other hand, it also helps us prevent over-treatment or under-treatment. So there are situations where we think of a tumor that is high grade or large in size that could have a high risk for recurrence, but in reality comes back with a low risk of recurrence, and therefore we avoid chemotherapy, and that happens in 25% of the patients. And on the other hand, there could be tumors that look small and unremarkable when the pathologist looks under the microscope, but on the other hand are found to have a high risk of recurrence, and we can avoid undertreating them. So the way I tell it many times, we try to find out if we have a wolf in sheep's clothes or otherwise. And we do know that integrating the pathology details and this recurrence score is important, and putting all together with the tumor size, the age, and the grade, which means the degree of aggressiveness of the tumor. We have another computer model that we can use that is called RS-Clean. I said earlier that patients who have a recurrence score less than 25, we usually think of them as having a low risk of recurrence, but when you use such a model, one could see that for a tumor that is 2 centimeter and more aggressive, a grade 3, actually it turns out that there could be an individualized absolute chemotherapy benefit of 5%, and such a patient would be treated. So we use these tools in clinical practice to basically decide in the utility of chemotherapy, especially for patients with who do not have cancer that spread to the lymph nodes. For patients where the cancer did spread to the lymph nodes in general, we think of a higher risk of recurrence, and the standard of care has been to offer chemotherapy. And that used to be the standard recommendation. Still, the results of this clinical trial called RxPonder came out. So this clinical trial randomized patients with 1 to 3 positive lymph nodes without distant metastases to receive chemotherapy followed by endocrine therapy versus endocrine therapy. Did not make a risk of disease recurrence. However, the situation was different for patients with who were premenopausal at the time of the diagnosis, and in such patients there was a benefit. This gray line depicts the risk of recurrence that increases over time for patients receiving endocrine therapy alone, and that risk of recurrence was lower if the chemotherapy was added. But and the same way I showed that there was this clinical RS-Clean model for patients who do not have lymph node involvement that adds to our ability to predict the chemotherapy benefit. Dr. Pushtai from Yale Smilow Cancer Center presented this year at the major oncology conference called ASCO, the development of an RS-Clean model for patients with positive lymph nodes. And that will be soon available for routine use in clinical practice. So the questions for the premenopausal women is, how is the chemotherapy making a difference? Is it because the chemotherapy forces the women to go into early menopause, it suppresses their ovaries, or is there any added cytotoxic benefit from that? And it was interesting that this year at ASCO 2024, that happened in June in Chicago, there was a subset analysis that tried to look at the menopausal status of the women who were treated. And it was found that there is a blood test that is called serum anti-Mullerian hormone that could be used as a surrogate for the ovarian function. So it was found that women who are younger than 55, who are at the age of their final menstrual period or later, tend to have a low anti-Mullerian hormone that is less than 10%, less than 10, and that correlated with the chemotherapy benefit. So in other words, there could be premenopausal women who still have periods, but who have a very low ovarian reserve and ovarian function, as expressed by this low anti-Mullerian hormone level, and who would not really have any benefit from the chemotherapy. Whereas the women who still have a medium or high anti-Mullerian hormone, although, and are premenopausal and less than and younger than 55, would benefit from the chemotherapy. And that actually brings additional support to the idea that maybe the benefit of the chemotherapy in premenopausal women with 1 to 3 lymph node involvement comes from suppressing the ovarian function. And we are currently enrolling patients in this clinical trial called OFFSET, which is run across the United States and basically is trying to answer the specific question about what would be the role of adding adjuvant chemotherapy to ovarian function suppression in premenopausal women with a low recurrence score and either node negative or with 1 to 3 lymph node involvement. So we do know that based on that most of the women diagnosed with early breast cancer that is hormone receptor positive and HER2 negative would need to take the anti-hormonal therapy for at least 5 years. And there are certain clinical circumstances when we would recommend extending the duration of anti-hormonal therapy to 7 or maybe 10 years, depending on the initial high clinical risk. And we do know, for instance, if someone has more than 4 lymph nodes involved, or if there is a large tumor, especially if it was higher grade, we would encourage women to continue the anti-hormonal therapy for a longer duration past 5 years because the risk of recurrence in the later years is high. However, there are smaller node negative tumors where it is unclear if the risk, of the side effects from extended endocrine therapy is justified, and maybe there is no need to continue. And we do have another genomic testing called breast cancer index that has a predictive and prognostic value in determining the benefit of such extended endocrine therapy. And that can be used for patients who have node involvement or not. And again, that a portion of the tissue removed at the time of the surgery that is being stored in the pathology department for years to come is sent to a special laboratory, and then we do get a report that has a predictive value telling us if there is any benefit from additional endocrine therapy, and you get here yes or no. And then it has also a prognostic implication because it gives you a risk estimation. What would be the risk if you stop the endocrine therapy at 5 years or if you continue to 10 years? And I put here a test result where the extended endocrine therapy is indicated, but we do know that most often we get like a no for a predictive value and a low risk for late recurrence. So a study done by Dr. Sanft from the Yale Cancer Center showed that using this breast cancer index can change the treatment recommendations in up to 30% of the patients. And also what was documented was that having the results predicting a high risk of recurrence encouraged the patients to be more compliant. We do know that the compliance with taking the anti-hormonal therapy decreases over time. So there are reports that say that almost only half of the patients would take their anti-hormonal medication, anastrozole or tamoxifen every day at year 5. And once those results are known, especially if there is a high risk of recurrence, that compliance could increase up to 80%. So for patients at high risk for recurrence, we have other interventions that other treatment options that we can offer our patients. And we know that we have this class of medications called CDK4/6 inhibitors and 3 different medications, abemaciclib, ribociclib, and palbociclib, and the first 2 of them were proven to have a benefit in adjuvant setting. So we know that this class of medications are also called cell cycle inhibitors, and they disrupt the cell cycles, preventing the cancer cells from replicating when they get that instructions from the estrogenic stimulation, from the hormonal stimulation. So we can think of these cell cycle inhibitors as enhancing and supporting the efficacy of the anti-hormonal medication. So the first trial that showed us the benefit of such drug was called Monarch-E, reported a couple of years ago, where patients considered at high risk for recurrence based on the lymph node involvement or more than 4 or 1 to 3 lymph nodes plus other high-risk features such as having a grade 3 or a tumor larger than 5 centimeter were randomized to receive this anastrozole or aromatase inhibitor plus abemaciclib versus the hormonal therapy, anti-hormonal therapy alone. And it was shown that patients taking the combination therapy remain free of disease better than patients taking the endocrine therapy alone. And this is called invasive disease-free survival. And it was also noted that this benefit increases the adjuvant hormonal therapies continued alone. But we do know that as I said, the benefit continues to increase over time. So that led to the FDA approval of this medication in October of 2021 for hormone receptor positive, HER2 negative stage 2 and 3 early breast cancer at high risk of recurrence. Initially, there was a requirement for the tumors, for the cancers to show a high proliferation rate, but that was subsequently dropped. So more recently, we had the results of another clinical trial called NATALEE that uses a different CDK4/6 inhibitor that is called ribociclib. And this expands the number of patients who can receive such a treatment because it includes lower risk patients, stage 2, 2A, 2B, 2-3 without positive lymph nodes or with positive lymph nodes. And in this case, the ribociclib is given 3 weeks on, 1 week off for the first 3 years of the endocrine therapy. And the benefit was seen as in this invasive disease-free survival analysis at 4 years, that it was almost a 5% difference at 4 years. And that, again, as in the Monarchy trial, the benefit increases over time. And that applied to stage 2 or stage 3 patients, and also to those who had the positive, who didn't have lymph node involvement, or who had involvement of the lymph nodes. So we are very happy to say that FDA approved this medication very recently on September 17th, and we have patients already receiving this medication in our practice. So how do you choose between the two medications? Well, the choice depends on the access, the side effects, and comorbidities, the safety profile, and the patient preference. There are certain categories that patients should fall in to qualify for one medication or another. And we also, it's important to emphasize that for certain patients who are carrier of a genetic predisposition for such as BRCA or BRCA, they may be eligible for a different type of adjuvant treatment that could enhance their chance for cure. So how do we choose between them? It also depends on the side effects. We do know that one of the major side effects of abemaciclib or Verzenio is diarrhea, whereas ribociclib is more associated with QT prolongation, which is some type of EKG change that requires close monitoring. And both medications can increase the risk for low white blood cell count, abnormal liver function test, or interstitial lung disease, but those are relatively low, especially the last one, a relatively less common complication, and we are very well versed in monitoring patients very carefully with guidelines, like emphasizing what the standard of care is. So we do know that there are different attempts to try to increase the tolerability of the medication, and maybe starting at a lower dose and gradually increasing the medication will increase the compliance. And this is the subject of the clinical trial called TRADE. So in conclusion, the adjuvant treatment for hormone receptor positive, HER2 negative early breast risk. And we talked about how we can de-escalate the therapy by avoiding chemotherapy when the benefit is very small and it doesn't justify the risk of side effects, and it doesn't make an impact in reducing the risk of recurrence, and also limiting the endocrine therapy to 5 years. But on the other hand, we are ready to increase the intensity of the therapy, either by extending the adjuvant hormone therapy beyond 5 years, and or adding this new class of medications called CDK4/6 inhibitors, or adding specific medications in selected cases of BRCA mutation carriers. But ultimately, our efforts should be to pursue new developments and continue to improve in our outcomes by enrolling patients in clinical trials and taking advantage of all the clinical research that is done through Yale Cancer Center at Smilow, Waterford. Thank you for your attention.
Okay. Do you want to check and see if there's any questions, Anca, for you?
I don't see any questions at this time.
Okay, so I'll just go right into the breast cancer and radiation. Thank you all for those of you who have stayed on. This will be a little bit more light. in terms of the content. So let me just, I'm sharing my screen here. Give me 1 second. Are you seeing my slides, Anca?
Yeah.
Okay, all right, great. Let's start from the beginning. Okay, here we go. So what are the indications for breast radiation? We do it in the post-lumpectomy setting. Let me get rid of this thing. In the post-lumpectomy setting and the post-mastectomy setting for high-risk patients, we use it to palliate patients who have distant metastasis, where they're having pain or symptoms, and we're trying to make them just feel better without eradicating disease. And also, very rarely we'll use it preoperatively. So the two things that I'm going to focus on are the first two, which is the vast majority of what we see. But most people don't know a lot about radiation. We're not even taught it in medical school, actually. And so it's very interesting, the history of radiation. And I thought I'd just start by that. Radiation was first discovered at the turn of the 19th century when it was 1895, and William Röntgen, who was a physician, actually discovered it. And it was 2 months from the time that he reported it that a medical student in Chicago went to his family warehouse where they were manufacturing lights and tubes and actually treated a patient who was 65 years old with recurrent breast cancer with radiation. So that was the first patient that has historically been documented as being treated. Many of you have probably heard of Marie Curie. She's the name that's associated with radiation therapy. She dedicated her life to developments in breast cancer, and she discovered polonium and radium, which were two of the earlier radiation sources that were used. She championed using radiation therapy in medicine and really developed our understanding. And for this, she actually won the Nobel Prize in Physics. Unfortunately, she died at a relatively young age, 66, and she died of complications of all of her radiation exposure, which was aplastic pernicious anemia. So unfortunately, we had a lot to learn early on about radiation therapy. It was thought to initially be considered something like liquid gold or gold. They used it in all kinds of application. They put it in beauty creams, in powders, in face masks, permanent hair removal. They had this device here that's sketched out, shows you a woman whose face is being put in because she wants to remove hair, acne treatment, razors for smoother shaves, arthritis, gout, rheumatism, tonsillitis. They radiated little kids, food sterilization, and also to toothpaste, soaps, paints, food, cigars and cigarettes, water, and fertilizer. And again, this was very, very early when we didn't know much about radiation. But then there started to be reports of the long-term toxicities of radiation, which primarily were very, very bad hematologic and soft tissue cancers and disorders. And it wasn't until this, the radium, they would call them the radium girls. These were women who were using radium paint. It was called radium paint, and they used it to actually paint the dials in factories to make the dials light up. And it was when that women within these factories started all getting sick that they realized something bad is really going on with radiation. And that's when all of the products stopped, they started to stop using them. So in terms of radiation for medical purposes, the early part of the 1900s, the sources were actually put into devices, and then the devices were put next to the tumors. So as you can imagine, they had to create all kinds of devices to put patients' tumors next to these sources. And then here's another image here. You can see an applicator where it's put into the mouth because this patient has a tongue tumor, and the source is delivered within there. The first linear accelerator was actually in the United States was in 1955 at Stanford University in California. And the first patient ever treated was a young patient with recurrent retinoblastoma. So then linear accelerators started to be developed. The first ones were called cobalt linear accelerators. These linear accelerators had an active source in them. So if you were in the room, like this patient is here, but you see this nurse here, she's getting exposure because there's an active source. And it wasn't until about the 1970s that the linear accelerator tubes were created, and we started replacing all of the live sources. And since then, it's just been a rapid progression of technology for radiation therapy. This is what our current linear accelerators look like. They're very sophisticated, and I'm going to go over some of the details of how the delivery is done. But first, I think it's important to kind of understand, what does radiation do? So radiation is a high energy X-ray beam, and it causes damage to the cell's DNA. Now, normal tissues have a way of repairing themselves, whereas cancer cells do not. And radiation causes direct damage to the DNA of the tumor cells, and it also causes indirect injury by interacting with water that's in the area of the cell and developing free radicals. And then these free radicals cause damage. So this is a twofold mechanism of how the injury affects these tumor cells and prevents them from continuing to reproduce. So what radiation dose is safe? Well, it really depends on the surrounding normal tissue. Every site in the body has a dose that's safe based on what's around it, because it's the normal tissue around it that is limiting what we can deliver. Okay, so when we're speaking specifically about breast cancer, the things in the area are the soft tissue, the nerves that go up through the arm, the chest wall, the lung, and the heart. And so all of these have subsequently, we have found safe doses that the normal tissue can tolerate. And based on that, we have regimens that we use for breast cancer. Now, moving on to the breast conservation therapy, as Dr. Proussaloglou mentioned earlier, mastectomy used to be the standard of care. A woman came in the 1950s, 60s, 70s. It was highly likely that she was going to have a mastectomy, even for a tiny little tumor. It wasn't until later in the 1970s that breast conservation was established. And breast conservation is defined as complete removal of the primary tumor with a negative margin, followed by whole breast radiation. And what numerous studies have definitively shown, is that when you do a mastectomy, whether you do a mastectomy or you do a lumpectomy or breast conserving surgery, followed by radiation to the whole breast, there is absolutely no difference in survival. This is the survival curve. As you can see here, both the mastectomy and breast conserving therapy arms are basically superimposing each other. So I mentioned margins. What is a margin? Okay, well, a margin is basically assessment of how close that tumor is to where the surgeon cut. So a negative margin, or might be called a clear margin, means that the cancer cells around the edges of the specimen that was removed are clear. So when a pathologist looks at the individual cells under a microscope, what they see is that the distance between where the area that was cut and the actual cells is wide enough so that the probability of having additional cells beyond that is going to be low. However, when you have a positive margin, the tumor cells are butting up against the edges of the specimen. And so that there's a higher probability that there might be cells beyond that area. Okay, and this has been an area of controversy for a long time. What constitutes a negative versus a positive margin? How much distance do we need? So here's an example of a patient who has this is a duct that you're seeing here. That's a malignant duct. And here's the margin that you can see with my arrow. And it's not actually touching the margin, but is this a negative margin or a positive margin? And then here's other examples. Here's the tumor right here that I've outlined for you. And here is the ink that's where the specimen was cut. There is a 2 millimeter margin here. And in this one, here's the tumor, and it's 1 millimeter away from the closest margin. So again, this concept of what is a negative margin has been disputed for many, many decades. And re-excision rates were reported to be as high as 40–45% for patients undergoing breast conserving surgery. And so one of the largest projects I've worked on in my career was to try to identify how we can, as a multidisciplinary group, come together and figure out what would be an ideal margin for both invasive cancers and DCIS. And so we got a group of experts together and did a consensus recommendation guideline. And what we determined was, based on all of the published data, that an invasive cancer or an invasive cancer that has DCIS has no tumor cells that are actually directly touching ink. So that first image that I showed you, where it was just a little bit away, that's okay if it's an invasive cancer. For DCIS, however, because the natural history is different, because the anatomy is different, there are more branching and more multifocal lesions and more skip lesions, the DCIS margin is actually wider. It's 2 millimeters. And anything more than what these two guidelines say are actually not necessary. It does not improve outcomes. And this now, fast forwarding 9 years since the initial guideline was published, has been widely accepted by multiple organizations and is considered standard. And it's been shown to significantly have decreased the re-excision rate. So whereas we had 25 to 45% of women having to go back for additional surgeries after a lumpectomy, now it's well under 20%. And actually, there's data that shows that mastectomy rates have also been decreased because of that. So it's a little confusing as to which guideline needs to be used, and it's something that you can discuss with the surgeon if you're unclear about it. However, it has been identified and delineated. So in terms of breast conservation, we now have multiple trials, actually 17 of them. Those are prospective randomized trials that looked at doing just a lumpectomy alone versus a lumpectomy and adding in whole breast radiation, over 10,000 patients. And all of these studies together show that radiation therapy significantly decreases the risk of the cancer coming back within the breast and within the nodes by about 2/3 of risk reduction. In addition, we now know that not only does it eradicate disease locally, but it actually prevents microscopic disease from spreading to distant sites and affects survival. And that is a proportional benefit across all stages, and the relative benefit varies with significant risk factors and with stage. So again, the Oxford meta-analysis showed that this radiation benefit is really significant across all patient subsets. So whether you have a T1, T2, ER positive, ER negative, whether you're getting tamoxifen, not getting tamoxifen, radiation substantially decreases the risk of the cancer coming back. So then are there any patients who we can not give radiation to? So when you looked at these breast conservation trials, the vast majority of patients that were enrolled were all under the age of 70. And we know for women 70 and older, they tend to have more indolent or slow growing cancers. And so there have now been 2 studies that have been published. One is 70 and older, as you can see here. This one is 65 and older. And these looked at randomizing patients to the standard, which is now doing radiation with tamoxifen or just giving tamoxifen alone. And what these studies both very similarly showed is that, yes, radiation does decrease local regional recurrences. However, it doesn't affect survival. And that's because if a recurrence happens, they can then go on and have it salvaged. They can go on and have another surgery and get it taken care of later. So this is a good opportunity for women who don't have such a long life expectancy, or if they're not concerned about recurrences and that they're willing to take their chances with that, and they're willing to commit to endocrine therapy, that they can consider omission of radiation. And this is a standard option that we do discuss with patients that meet these eligibility criteria. So there are now other trials that are ongoing, trying to increase that eligibility criteria even more. There was a study that looked at 50 and over and found that the recurrence rates were really, really high, just using clinical and surgical pathologic features, that kind of thing. So now this newer generation of studies are actually adding in either biological markers or genomic assays or immunohistochemistry testing, something other than just the clinical pathologic features in a younger subset of patients to try to identify patients who will be low risk enough that we might be able to forego radiation. And this will be promising, hopefully promising data once it comes out. Moving on to fractionation for radiation. So all the studies that were done that I mentioned to you, the established breast conservation therapy, and the vast majority of them that established mastectomy treatment, used conventional fractionation. And by that, I mean they got 5 weeks to the whole breast or to the chest wall. And then if they added in a boost, which was the tumor bed, it was up to 7 weeks. So that's a very long time to get radiated. We have subsequently found out that giving a larger daily fraction to the same target with a lower total dose, but that's biologically equivalent, gives a shorter treatment time and in fact has less acute toxicity and equal long-term toxicity. And so now we're moving towards the standard of care being between 3 and 4 weeks, which is a huge deal. It doesn't seem like a lot, but it's a huge deal for patients. That additional 2 weeks, especially with the toxicity of it, is quite significant. And more recently, particularly since COVID, we have these ultra hypofractionated regimens, which are 5 fractions delivered to the whole breast. They can be delivered once a week for 5 weeks, or 5 consecutive fractions, Monday through Friday, in 1 week, and then you're done. And again, these are larger daily doses to that same volume. However, they're biologically equivalent. So what about post-mastectomy radiation? Well, similar to breast conservation, post-mastectomy radiation has been shown to decrease not just local recurrence and regional recurrence, but also prevent distant metastasis. And in high-risk patients who might have a higher risk of disease in that local regional area after surgery and after chemotherapy, giving post-mastectomy radiation provides a unique opportunity to eradicate that disease before it has a chance to spread and prevents distant metastasis. And there are multiple studies now that show that breast cancer specific related deaths were significantly decreased with the use of post-mastectomy radiation in patients who have positive nodes. However, unfortunately, the older studies showed us that the radiation techniques were not that great, and the surrounding tissue that I talked to you about, the cardiac, the heart, the lungs, were getting radiation. And if these patients lived 10, 15 years, they were then not dying of breast cancer, but dying of cardiac disease. They were dying of lung disease. And so therefore, we were improving their breast cancer outcomes, but we were increasing their cardiac and their lung morbidity, and it kind of negated each other. So the overall survival was actually negated. And this is a nice analysis that was done in 2005, showing that the mortality from circulatory disease, cardiac disease, pulmonary embolism, and lung cancer was significantly higher. And so the focus of radiation therapy trials predominantly, and the advances that have been made in the last several decades have been to try to minimize the toxicity of radiation. And you can see based on this analysis here, before 1970, okay, cardiac mortality increased 20 to 21% in patients who received left-sided breast radiation or post-mastectomy radiation. And you can see here, after 1993, there was no increase in cardiac mortality. And this actually kind of tilted the scale. So now we're seeing more of a survival benefit than we did before, because now the cardiac and the lung toxicity has significantly gone down. And we see that here. You can see that when you look at the mortality, there is a significant benefit in patients in 1 to 3 and in 4 or more positive nodes with post-mastectomy radiation. So how have we achieved this? Okay, we've achieved this by improving how we immobilize the patient. Okay, it's really critical that the patient be in the same exact position every day. And we have various ways of doing that, but the patient needs to be immobilized. So these are just various images showing you, here we have what we call a back lock with the patient's arms above their head, and they're on an incline, which is a breastboard. Here we have a patient in what we call a sling, immobilizing their breast. And this patient is in the prone position with their breast immobilized. So the first thing we do is a CT simulation. The CT simulation, for those of you who may have family members or have had breast cancer yourselves, that has also rapidly evolved over the last several decades, because before we only had 2-dimensional ways of doing the CT simulation. Now we actually use a CT scanner and get 3-millimeter slices across the entire chest, and then use that to draw out what the individual patient's anatomy looks like, define what those borders are that we need to treat, and actually plan the radiation in a way that we are personalizing the beams to the patient's anatomy. And we do this using a very standardized approach. There are now multiple atlases that help us to delineate. So across physicians, across the country, across the world, actually, we have specific definitions of how to define where breast tissue ends, where the chest wall ends, where lymph node drainage goes. And so ultimately, we come up with a plan that involves treating, for example, in this patient who has an intact breast, we treat the medial portion of the breast. Then the machine moves around and goes to the lateral or the outside of the body and treats the outside portion of the breast. So ultimately, what you have is a beam that transects through your body and looks like this. Okay. However, again, everyone's anatomy is going to be different. And so you're going to see, if you use that same beam across every patient, some people have smaller breasts, some people have larger chest wall. Some people have larger breasts. It's going to be different. So when we used to treat with two-dimensional treatment planning techniques, this is what we would see. We would see these hot spots where the radiation dose was really, really hot, and other places where it was less hot. And this is what caused a lot of the problems, not just for the lung and the cardiac issues that I mentioned, but also for the breast and the soft tissue. So why were the two-dimensional techniques a problem? Well, these hot spots, if you look at this on a slice kind of going through the mid-plane, this hot spot right here corresponds to a patient who has, you can see the skin peeling right here during the last week of radiation. So this is, extremely uncomfortable, and the patient's dealing with this because of this hot spot. Similarly, in the inferior portion of the breast, you see this hot spot corresponding to the inframammary fold right underneath the breast. Again, lots of peeling, risk of infection, all that kind of stuff. Things that we have subsequently learned to avoid. So how do we avoid it? As I mentioned, we take these 3mm slices, we contour out all of the breast tissue, all of the nodes, the areas at risk. We contour out the normal tissue, the heart, the lungs, the liver, if it's right-sided. And then we use sub-beams to actually modify at each level where these hot spots and cold spots are to block them and to modify in between so that each beam is very much tailored for the individual patient's body. This is what a 3D or an IMRT patients look like during their last week of treatment. You can see how much better their skin looks. There's no desquamation, and the skin is less red because we're actually sparing that superficial skin as well, because it doesn't need to be treated in the vast majority of patients. So in terms of decreasing heart and lung, there's two major techniques that we've started to use over the last 2 decades that have really substantially decreased the heart and lung toxicity. The first one is prone positioning. Patient, again, has to lie with their arms up over their head. The contralateral breast is moved out of the way, and we use gravity to lay the breast forward. And by doing this, we can treat with the beams medially and laterally so that the breast is falling away from the chest wall, and we can spare, even in a patient who has a large breast and has a heart that's abutting up against the chest wall, we can avoid treatment of their heart by using this positioning. The other thing is deep inspiration breath hold. That's DIBH. We use multiple lasers in the room that are then projected onto the body. And what that allows us to do is to monitor the exact 3-dimensional position of where the chest wall is. Why do we do that? Well, because when we are able to use those lasers, we can then have the patient get into a breath hold position. They take a deep breath. When they take a deep breath, their heart moves away from the chest wall. And when they're in the exact position that we need them to be in, the machine will turn on. And I'll show you what that looks like. So this is the deep inspiration breath hold. Here's a patient with free breathing. You see that they're in their normal breath, their heart is up against the chest wall. So if we were to do a tangential beam, this is what it would look like. When we have the patient take a deep breath and we put that same tangential border on, you see how the heart has moved away from the chest wall. So this is the position, the one on the right is the position we want the patient to be in every day while they're getting treated. So how do we achieve that? What we do is we use the surface imaging, and patients are set up with these lasers that are non-invasive. If there's camera in the room, it doesn't require any specific markers. It doesn't require additional radiation, and it's actually linked to the treatment machine. So we ask the patient to take a breath, and when they get into that same position at the same level within a 3 millimeter threshold, the machine will turn on. And as soon as they release their breath, the machine turns off. And that is how we are able to treat them so precisely and stay off of their heart and their liver and actually decrease their lung volumes as well. So this is what it looks like. You have the reference image, which is the one we get at the time of CT simulation. We ask the patient to take a breath, we get that reference image. And then on a day-to-day basis, when they come in, we have them come into the room, they take a breath, they hold their breath. And this is what it looks like. We put up the reference image from the CT scan. We then take the daily verification image, is what they're doing. And then we make sure that they get into that threshold of 3 millimeters. And the couch calculates exactly what needs to happen for them to get there. So here is what the screen looks like for us. Here's a patient. You can see there's pink and there's green. So the pink and the green are the reference image and the verification image. They are not within that threshold. You see all this red here. And so therefore the beam is held. It is not turned on. However, when the patient, now you see a lot less pink here, it's all green, patient falls into that threshold, you see that the beam is enabled and the machine will stay on so long as the patient stays in that position. As soon as they release that position, the machine goes off. And these technologies have actually really improved radiation therapy outcomes. So the efficacy of radiation is the same, but the toxicity has been decreased. So overall, the threshold for treatment and the overall advantage of radiation has been improved by minimizing toxicity. The other thing that we have started doing over the last decade is, instead of treating the whole breast for patients who undergo breast conservation, there are patients who are low risk that are eligible for partial breast. And there's various ways of doing that. It can be done with the linear accelerator on the treatment machine, or there are ways to actually put catheters into the lumpectomy or the tumor bed at the time of surgery and deliver radiation that way. However, this, I would say, is the most commonly used technique. This has now been adopted by the NCCN, and the most preferred regimen is the one where 5 fractions are given once every other day using that technique that I just showed you on the last image. So in conclusion, there have been a lot of advances made, primarily technological, that allow for safer and more precise delivery of radiation. We are now tailoring the radiation beams to the patient's individual anatomy using 3-dimensional treatment planning. We minimize the normal tissue exposure to the heart and lung, and we're also learning and using about de-escalation strategies, which patients are eligible for radiation omission. They have a higher local relapse rate or regional relapse rate, but it doesn't affect survival. So based on the patient's preference, they can decide whether they want to get radiated or not if they meet those criteria. We're also doing more partial breast, which is smaller volumes given in a shorter time. And we also have these shorter whole breast radiation therapy regimens that are allowing for less acute toxicity and are beneficial in terms of a convenience and medical costs. So we're identifying more patients now who can, and as Dr. Proussaloglou discussed, we can omit axillary surgery for. And I didn't go into the studies with that, but we are delivering more radiation therapy to the axilla now because patients are getting less axillary surgery. So we're just sterilizing the area with radiation. And of course, this benefits the patient in less morbidity of the surgery and less lymphedema. Radiation therapy, both in the mastectomy and in the breast conservation therapy setting, have improved all of the breast cancer outcomes. and it decreases not just local regional relapse, but it prevents distant recurrence. And if a patient's going to live long enough, 10 to 15 years, they have the potential of having a survival benefit just from the radiation alone. So I think the future studies are attempting to identify additional patients in whom we can safely omit radiation. However, they're using things like biological subtypes and genomic assays and immunohistochemical staining to try to really figure out which patients are truly low risk and are not going to benefit from radiation versus those who will benefit from radiation if they live long enough. And so I will leave you guys with that. And if anyone has any questions, I'm happy to answer them. I can't see the
Fantastic. Thank you, Dr. Moran. I don't see any questions in the Q&A. I think we've answered all questions possible, but we'll give another moment or two in case any of the participants want to chime in. Otherwise, I think this was such a great presentation with a real sort of tour de force of all of the ways that we help take care of breast cancer. I hope it was helpful for all the participants. I know that this isn't being recorded and will be added to the website and to the YouTube as well in case people have questions or want to look back at the data. We're getting some nice thank yous coming in through the chat, but really appreciate everyone's time, and I think we'll let everyone enjoy the rest of their evening.
Thank you so much, everyone, for joining us.
Thanks all. Bye-bye.
Thank you.